last time we left off at the end of all of our lipid lowering agents, so we talked about hypertension and management of uh, decreasing your myocardial oxygen demand for angina and heart failure. So now we're up to cardiac glycosides, and soon enough we're going to be at the antiarrhythmics, which are the bulk of cardiovascular pharmacology. One medication I put here, dobutamine, up here, is just a snippet from the pharmacology chapter because this is a cardiovascular medication, but it's not mentioned under cardiovascular pharmacology. So either they forgot or whatever, but it should have definitely been mentioned again in a little more depth here. So dobutamine, it's a medication that works on beta 1 receptors more than it does on beta 2, and it has a little bit of effect on alpha receptors as well. So dobutamine is used to increase cardiac contractility and cardiac output in patients with cardiogenic shock, primarily via its agonistic effects on beta 1 receptors. At high doses, it also has weak agonism at both beta 2 and alpha 1 receptors. Major adverse effects include hypertension and increased risk of arrhythmia. So in essence, dobutamine is very, very similar to carvedilol and labetalol, right? Except those guys are beta blockers. This is a beta agonist, right? So that's the difference there. It works on the same receptors, but those guys, the LOLs, those are blockers, right? Dobutamine is not an LOL medication, so it doesn't block anything. So the reason I bring this up is because you can actually get a pharmacology question where they'll show you like, a normal cardiovascular curve, and then maybe they gave the patient a medication X, and something changed. Maybe that change is increased contractility and cardiac output, right? Whatever the curve might be is showing you that. And then they give another drug Y, and it completely undoes everything that drug X did, right? And then they'll give you two answer choices: what is drug X, what is drug Y, and you should be able to figure out that drug X might have been like dobutamine, and drug Y was possibly carvedilol, right? Where depending on what things they're showing you in the curves, they'll be depicting to you what's changing, right? And that's a very common type of pharmacology question that you get, especially when they want to test you on effects of epinephrine and stuff and beta blockers. So that's the kind of stuff that really comes up, and you have to be very confident in knowing what receptors are being affected, so you can know what receptors are being blocked by the second drug that altered the events and stuff. And that's something that you definitely want to be aware of. Let me see. Okay. So that's dobutamine. The next one, Digoxin, also a medication that increases contractility. So now we get to see the full breakdown of exactly how Digoxin does what it does, right? So let me see if I could just fit everything. Okay, perfect. So Digoxin, direct inhibition of the sodium-potassium ATPase, leading to indirect inhibition of the sodium-calcium exchanger, and that leads to increased intracellular calcium, which obviously leads to more calcium-induced calcium release, and you're going to have increased inotropy. But that's the easy part. That's the part that everyone remembers very well, right? You're increasing contractility. The other thing you need to remember, it is also stimulates the vagus nerve, right? And the vagus nerve is parasympathetic. So if it stimulates the vagus nerve, you're going to decrease heart rate, right? Parasympathetic is rest and digest kind of thing. So that's the second, mechanism that you definitely need to remember. So how does this direct inhibition work? So you can see in the picture here that Digoxin kind of blocks the potassium entry of the sodium-potassium ATPase. So if potassium is not coming in, sodium is not going out. That is the direct thing that's being blocked, right? Because sodium is staying inside, you indirectly turn off the sodium-calcium exchanger because that's not going to bring in more sodium. If you have a lot of sodium inside already, you're not going to bring in more sodium, so then you're not going to kick out any calcium. That indirectly gets inhibited, so you have a bunch of calcium that now gets to stay inside the sarcoplasmic reticulum, right? And then, of course, when you finally have contraction, sarcoplasmic reticulum is going to release a lot of calcium, which obviously goes and binds tropin and C, which we learned when we did the physiology earlier, and we're going to see a little more when we do physiology of MSK. And that tropin and C calcium binding leads to cardiac contraction, right? Now, way in the beginning of cardiovascular physiology, remember, repetition is key. Way in the beginning, we learned about some of the things that were on the sarcoplasmic reticulum, right? We learned about the phospholamban and the circa ATPase, right? So if you forgot about that, this is a great time to go back and take a look at that. So let's just go ahead and do like a little quick revision of that, right? Because we're at the end of cardiovascular. So now is when you always want to go back and like make final ties of everything and make sure you grasped it all, right? So this is the same thing we're looking at again, right? Sodium, potassium, sodium, calcium, right? And this is what's being blocked by digoxin. So you see your sarcoplasmic reticulum. This is where all the calcium was inside. And you have your phospholamban and circa ATPase. And you're supposed to remember what those guys do, right? Where is it? Right here. You see phospholamban inhibits circa, lowering contractility by limiting the amount of calcium that goes inside your sarcoplasmic reticulum. Circa's job is, the ATPase, its job is to bring calcium inside. Right? You can see that happening. Calcium going by the ATPase goes inside. Phospholamban stops that circa ATPase from doing its job. All right. So when you take medications that work with beta 1 receptors, right, that activates GS, which leads to more cyclic AMP, which makes pKa, and pKa actually phosphorylates and inhibits phospholamban. So that's how beta 1 receptors increase contractility, right? Beta 1 receptors turn off your PLB because of the protein kinase A going to the phospholamban and inhibiting it. All right, so that's a little bit of physiology that you definitely want to always remember, because now we're doing the pharmacology aspect of things, and again, those receptors are always going to come up, so you have to know the physiology, because all of that is going to be in your answer choices. Even if you remember it's a beta 1 receptor, heck, even if you remember it's going to be cyclic AMP and pKa, but you have to remember phospholamban getting inhibited by phosphorylation, thereby no longer being able to stop the circa ATPase. So the ATPase puts a bunch of calcium inside your sarcoplasmic reticulum now, and in the next contraction, a shit ton of it will come out. All right, a lot more than usual. So that's definitely good revision right there. So that's probably what that little purple dot is about. That purple dot right there, this pink one I mean, is your circa ATPase, right? Putting calcium in here. Okay. So another note here, this is more information about digoxin and how it works coming from UWorld. So it's a positive inotropy, negative chronotropy, right? So it increases contractility, but it decreases heart rate, how fast. ECG findings of digoxin use include prolongation of the PR interval, premature ventricular beats, T-wave inversion or flattening, and downsloping of the ST segment depression, as well as a decrease in the QT interval. The indirect effect on vagal tone leads to bradyarrhythmia, which can manifest with AV block. Right? So you can see the clinical uses of it are, one, for heart failure by increasing contractility, but you're not increasing heart rate. Right? That's how it's different from other medications that would be a beta 1 agonist. A beta 1 agonist would also increase heart rate, and you don't really want to do that to someone who has heart failure. Right? But if you can increase their contractility of the heart failure and make it, work a little better, that's always great. It's also good for atrial fibrillation because through the parasympathetic effects, it lowers heart rate. Right? So atrial fibrillation, the issue is too fast of a heart rate. So you decrease the conduction at the AV node because that's where the parasympathetic nervous system works, and you depress the SA node. Right? And we saw where the parasympathetic stuff works when we were looking at another thing we can go back and check out, which was this stuff right here. Right, so when we saw here, we saw your parasympathetic vagus nerve coming from the solitary nucleus of your medulla, right, coming down here and working on your AV node and SA node. So this is the same parasympathetic nerve that's being upregulated indirectly by digoxin. Right, so that's your little tie-in to all of that over there. Now, adverse effects. So oftentimes you're going to see questions about a person who is taking a medication and they have weird blurry vision or weird vision of color. Right? And they don't really go into the details of what the vision difference is all about. So this is pretty critical here. So you get this weird thing with glycosides where you get a blurry yellow vision. Right? And the book tells you think of Van Gogh. So the reason they say that is because this is how some of his work looked like. Right? So this is Van Gogh, where you can see the blurry yellowing that's happening. So imagine looking at a human, and that's how it kind of shows up to you. So that's the blurry yellow vision that you want to keep in mind. All right. Can also lead to hyperkalemia, obviously, right? Because you're blocking potassium entrance, so you're going to have a lot of potassium that's accumulating outside. And normally, that shouldn't be the biggest issue. You should not be getting hyperkalemia. You should be able to manage that. But if you can't, if your body isn't able to figure out what to do with all that potassium that's stuck outside, that's going to indicate a poor prognosis. You can't take digoxin. Right? And if you can't take digoxin, well, think of why you were taking it. It might have been heart failure or AFib. those scenarios are also going to be really bad. All right. Factors predisposing to digoxin toxicity are, anytime you have a question about toxicity, you want to think, okay, something's not working, right? Something that's supposed to clear drugs is not working. So renal failure, decreased excretion. Hypokalemia is definitely going to be some kind of scenario which will predispose to toxicity, right? So hypokalemia, because remember, digoxin is kind of competing with potassium. If there's no potassium, the effects of digoxin are just going to be that much easier and that much more impactful, right? So it's a permissive effect for digoxin binding. And then any drugs, your VAQ drugs, that displace digoxin from tissue binding sites, thereby lowering the clearance, right? So same thing, decreased excretion and decreased clearance. So verapamil, amiodarone, quinidine, these medications are coming up real soon. These are other antiarrhythmics that you could be taking. These guys are actually going to make it difficult for you to clear out digoxin, thereby also causing excess digoxin, so you get toxicity. Then comes the antidote, right? So you get a patient who does somehow have digoxin toxicity. Either they tried committing suicide and overdosed, or one of these other issues have made it difficult for them to get rid of the digoxin in their body. So you get your slowly normalizing potassium. That's always important. There's never a scenario where you're supposed to normalize either sodium or potassium rapidly. You always normalize sodium very slowly too, right? Because otherwise you can get demyelination and stuff, or you could just cause the body to blow up, cells to blow up. And you always normalize potassium slowly as well. You could use a cardiac pacer. That's another antidote. But the real thing that you get tested on are the last two. First you use anti-digoxin Fab fragments, right? You're using antibodies to kill off the digoxin itself, and then magnesium. And why do we give magnesium? Magnesium is a cofactor for the sodium potassium ATPase. So you want the potassium ATPase to be working, so you give magnesium and it'll start working. All right. Now the other thing, I wasn't able to find pictures of this stuff, the ECG findings of digoxin use. They were very weird looking ECGs, but it is very important to understand why these changes are occurring, because this is what we're going to be looking at very soon when we start going to antiarrhythmics, right? So digoxin, they said that it increases, right, includes prolongation of the PR interval. So you're increasing the PR interval. Why? And this should be pretty understandable. Remember let me open up, actually, there should be, okay, yeah. So remember this image right here, right? So you have your QR, well, actually, wait, this is your, not this one right here, QRS, right? So you have your P, QRS, and then T. And this picture is one of my favorites because it kind of puts it on the same timestamp as your ventricular action potential, right? So when you're in the P wave, there's nothing here, right? The ventricle isn't doing anything yet, so it's just phase 4. Then when you have your QRS complex, which is actual ventricular depolarization, you could see, right, on your action potential thing that you have ventricular depolarization, right? So kind of showing you the timestamp of both things happening together. So if we say we increase the PR interval, right? Well, PR interval, that's from, let me see, you see your P and the QRS. So your PR interval goes from like here up to the R stuff, right? Why would this area of your ECG get longer? Well, that area of your ECG is all about the atria, not the ventricles, right? Because the ventricle itself is your QRS complex. So this area gets longer because the parasympathetic effects of digoxin were slowing down atrial depolarization. So this part gets longer. So you increase your PR interval, right? That also allows more time for your atria to put blood into your ventricles, right? So you increase filling time and stuff like that. So that's what's happening there. So you have an increased PR interval, which makes sense because you're decreasing heart rate. One of the ways that you can decrease heart rate really is to just increase the PR interval, because you can't make your QRS go any slower or anything like that. And the only way to decrease heart rate is how quickly this information from the atria get to the ventricles. So PR interval determines that. The other stuff is just things that can happen. So you don't necessarily need to know them, but they're there, and those can be things that show up on a test. You can literally have this description of an ECG, and then they can ask you what medication is the patient probably taking, and you have to be able to pick digoxin. Right? There are other medications we're going to see that also increase the PR interval, but understanding that these other things are happening, especially the decreasing QT interval, that's a pretty unique thing for digoxin. Not many medications decrease QT interval. There are tons that increase QT interval, predisposing you to torsades, right? So that's a whole different thing. All right, so that's it for that. Now, before we jump into antiarrhythmics, I do want to show you guys these pictures that we were looking at just now to really get a good idea of what things mean before we read them, right? So it's not all gibberish. So first things first, we did already look at our ventricular depolarization stuff, right? We understand this, the thing we made up, which was SOCA-POA, which was a play off of SOCA-TOA, the sine, cosine, and adjacent, and all of that, hypotenuse things, and tangent. Those are the things we learned when we were in trigonometry, right? SOCA-TOA was a way to memorize what angles you're supposed to use. We made up SOCA-POA for ventricular stuff because it is just sodium and calcium that comes in, and then potassium goes out. And you know nothing else comes in. It's really just sodium coming in, which causes the actual depolarization, calcium coming in during the whole contraction part, which causes the plateau, because at this point, as calcium is coming in, some potassium is leaving. Once calcium stops coming in, boom, a lot of potassium leaves, and potassium efflux is always repolarization. So that's the little summary of everything about how the ventricles are working. This image here reminds us of our AV and SA nodes. Right? Remember that phase 4 was your funny current, where you have your sodium and potassium both kind of, let me actually go back to that. Let me see how far up that was. Not too far. Yeah, right here. You see, so you have your sodium and potassium both going from extracellular to intracellular. They're coming into the cell. And you know they're coming into the cell, right? Because sodium and potassium are both kind of like, we're looking at right here. This is your phase 4, the funny current. In your funny current, sodium and potassium, both of them, little amounts of both of them, are coming into the cell. And you know they're definitely coming in because they're positive and you're making your charge more positive. At some point, you end up opening calcium channels and a bunch of calcium comes in, and it's actually calcium that causes the real depolarization of AV and SA nodes, right? And then repolarization is just potassium leaving, right? So that's it. And you have to remember that too. So phase 4, 0, and 3, there's no phase 1 where you have the initial tiny bit of repolarization, and there's no phase 2 where you have the plateau where calcium influx and potassium efflux are balancing each other. None of that is happening. Right, so that's your SA and AV nodal. This is your nodal action potential, right? Nodal action potential, and then this is your ventricular action potential. So that's what we're going to call them. And we already talked about the HCN, funny current stuff and everything, so that's all done for. All right, so let's take a look at our antiarrhythmic stuff. The other thing you need to know is the wording of stuff, right? So this image here tells you about the terminology. You have something called the effective refractory period, which we all know what the refractory period generally is supposed to mean. It's how long it takes for you to be able to do it again, and that's determined by this distance up here. How long it's going to take for another ventricular before you can have another ventricular depolarization. Your action potential duration is the bottom part, where you first went up and where you finally came back down. That entire time is your action potential, right? Because when you started, that's depolarizing, and until you don't come back down here, you're still repolarizing, all right? So the whole this segment here, the difference between APD and ERP is your relative refractory period. So you can get questions on any one of these three things, and you should know what they are. Right? So ERP plus RRP is your total APD, action potential duration. All right. So that's literally all you're going to really get much questions on. Now keep in mind, every time you see your ventricular action potential, think of what's happening with your ECG as well, right? If you're going to take this portion here, your phase 0, and you're going to make the slope longer of your phase 0, you will be increasing this part right here, right? Because you're going to slow down ventricular depolarization. Other than that, if you make repolarization occur faster, then you're going to decrease your QT distance, right? And really, if you make repolarization slower, you're going to increase QT interval, right? Because this is going to go much further like that, right? Much further. It's going to take a longer time. So if you increase QT interval, that's what we were talking about earlier, which can predispose you to torsades. So that's a little thing you want to watch out for. Here, I've put a little summary of what you should definitely know, which is class 1, class 2, class 3, class 4. Your 4 different classes of antiarrhythmics. They work with different things, right? So class 1 works with your phase 0 NA. Class 2 works with the nodal and uses beta blockers there. And class 3 antiarrhythmics works with the potassium channel, so it's going to affect repolarization a lot. And class 4 are actually your cardiac calcium channel blockers, so they work with calcium. So class 4 antiarrhythmics are actually the verapamil and diltiazem. So you should remember that's Na, beta, potassium, calcium is the order of 1, 2, 3, 4. Memorize it however you want to memorize it. Alright, so let's take a look at each one now and really grasp what's happening, because on your test you can be given this kind of picture and be asked what medication must have been given to the patient, and you have to identify just based off of this ventricular depolarization over here that this person was given class 1A. So what is class 1A, 1B, and 1C all about, and how are you going to get tested on them? So generally think of 1A as someone pushing the phase 0 from the left, like literally just pushing it, like pushing a wall. So you can see that, right? You pushed it from the left. That's phase 0. Later on in 1B, someone pushed phase 3 back, right? So there, it's like a pushing, rather than a tug of war, it's like more of a pushing war, right? And then again, class 1C pushed it and didn't bother the other side. So you see like the little visualization I'm trying to set up there, right? That's kind of what I did when I was trying to memorize it, right? So 1B, someone is pushing back on phase 3 from the right. Now 1C, they fixed the right and only push hard on the left on phase 0, right? 1B is better in post-MI patients, while 1C is contraindicated post-MI patients. And that's the general basics you need to know about all of them. Now we need to understand the mechanism and the names of these medications, right? So what do these guys do? These are antiarrhythmic sodium channel blockers. And sodium channel was all about phase 0. But some sodium channel blockers do have some effects on potassium. So they say slow or block conduction, especially in depolarized cells, decreased slope of phase 0 depolarization, are state-dependent, selectively depressed tissue that is frequently depolarized, right? So that little portion up there is actually something many medical students just read and completely forget and disregard, like no big deal, right? But it is a pretty big deal. Being state-dependent is actually one of the unique qualities of sodium channel blockers, right? State-dependent, as they explain, it selectively depresses tissue that is frequently depolarized. So it's choosing tissue, right? It's literally choosing tissue that that has been depolarizing a lot, right? So you're going to think of tissue that has maybe an AFib kind of thing going on, right? Any ventricular, maybe you have a VFib going on, or ventricular tachycardia where your ventricles are just beating at a faster rate than usual, right? Any of those issues are places where you're going to have excess depolarization, and sodium channel blockers choose those places. So that's good. That's like a medication that's targeting the problem. So you have class 1A, class 1B, and class 1C. 1A, you're supposed to remember them as your double quarter pounder, right? One double quarter pounder. A double quarter pounder, in case you don't know what that is actually a burger in McDonald's. And since McDonald's is pretty international, maybe everyone should know what that is, right? But a double quarter pounder is a really juicy looking burger. It's really freaking awesome. And this is supposed to remind you of the disopyramide, quinidine, and procainamide, double quarter pounder. You can always use the sentences that first aid has. That's perfectly fine too. Whatever works for you, really, right? So these medications are probably the ones that are really bad compared to the others that are happening. Relatively bad. They have some weird side effects that you definitely need to know. Quinidine is the easiest one to remember. It causes synchronism, right? So you're going to have this weird ringing in the ear and headache. Disopyramide is probably the worst, right? I wrote it here as the bad guy. It has a potent effect on suppressing fast sodium channels and can cause systolic dysfunction or acute heart failure, right? And they tell you here, heart failure, disopyramide. So imagine that, giving an antiarrhythmic to save someone's heart and then causing heart failure. So it seems like a terrible medication to give to someone. Next one, procainamide, we spoke very lightly about earlier when we talked about hydralazine. Procainamide also has lupus-like syndrome. Right, reversible lupus-like syndrome. So again, all the same things we talked about in the previous video just now discussing hydralazine are also now true about procainamide. So we have your, remember in SLE, you have LSE, Liebman-Sachs endocarditis, which is basically going to have vegetations on probably both sides of the valves. You're going to find antihistone antibodies, and those vegetations are not going to have any bacteria, right? So merantic vegetations. And that's really all there is to that. All right. So what are other issues you want to watch out for? Because it increases QT interval. You can see that right here. Increases QT interval. You could have torsades. So how does this increase QT interval? So I just told you, anytime you push this phase 3 further and you make this distance from here to here longer, if you make this distance here to here longer, you're predisposing yourself to torsades, because that distance from here to here is your QT interval. And we saw that up here. Remember, from here to the beginning of your T wave is your QT interval. And you can see that it's kind of marked by here to here. Right? You see your T wave is right up here. Right? And this distance is your action potential duration. So anytime you increase your action potential duration, or if you increase your effective refractory period, which basically by effect will increase your APD, anytime you increase on any of those guys, you are going to prolong QT interval, and that will predispose you to torsades. It doesn't mean it's definitely going to happen, but it can. All right, so this is becoming longer than what it was, so that's going to be torsades right there. Then you look at class 1B, right? And when you look at 1B, you can see you lowered the QT interval in a sense, right? It's not increasing, so there's no issue here of torsades. That's one thing that's gone. How do you remember them? So you remember them as lettuce, mayo, tomato, please, which is pretty much how you would order your food at like Subway, right? So lettuce, mayo, tomato, please. And that's going to remind you of lidocaine, mexiletine, tocainide, and phenytoin, right? They mentioned phenytoin here too. They'll tell you, yeah, phenytoin. Right, and tocainide is actually mentioned in a couple other books, but not in first aid. So these are all your medications for class 1B. They have a weak sodium channel blockade. They're not blocking sodium channels that hardcore. Right, and what do? They decrease the action potential duration, which you can see the distance from here to here got shortened. Right, preferentially affect ischemic or depolarized Purkinje and ventricular tissue, which is great. So they actually target damaged tissue, which is good. Phenytoin can also fall into this category. You can use this after an MI, right? 1B is best post-MI. And the way you want to think of that is because class 1B has weak sodium channel blockade, and you use it for a weak heart. Right? Weak sodium blockade for a weak heart. You can use it for acute ventricular arrhythmias, especially post-MI, and you could use it for digitalis or digoxin, same thing, induced arrhythmia. Right, this is a little thing you can get a specific question on. So you get a patient, he was taking digoxin, everything was fine. Then all of a sudden he ended up getting hyperkalemia from using digoxin, and hyperkalemia causes arrhythmias. Right, so that's something you definitely want to keep in mind. And then they'll be like, what should you give that patient immediately? Well, you can give them any one of these medications and they'll be alright. Looking at the graph, all you see is that the action potential duration became smaller. So repolarization is also happening a little earlier. And that's really all there is. Nothing major. So as I said earlier, we pushed in 1A from the left. In 1B, we pushed back from the right. In 1C, we're going to give a hard push on the left and fix it up on the right. So the right looks the same way as it always was. Your action potential duration is the same, so there's no torsades issue. All right, so let's take a look at 1C. 1C. Oh, sorry, adverse effects of 1B. So you have the one weird thing it does, and you should remember this for lidocaine at all times. Seizures, right? There's CNS stimulation or depression, and there's cardiovascular depression. I haven't really seen much about the cardiovascular depression part, but I've definitely seen seizures thing coming up for 1B, all right? So you definitely want to remember that, especially with lidocaine, it can happen. 1C is eat more potato fries, right? Eat more potato fries. So N-canide, flecainide, similar name, propafenone, and miracizine. These are all medications you can get for 1C as your answer choices. This guy has strong sodium channel blockade, so you can see the slope is super steep now. Right, so strong sodium channel blockade significantly prolongs the effective refractory period, because the distance from here to here, right? Remember your effective refractory period was up here. That distance is smaller now, right? This much smaller in the AV node and accessory bypass tract, but no effect on the effective refractory period in your Purkinje and ventricular tissue, and it has no effect on your action potential duration, right? Minimal effect, so you're not going to get torsades or anything. And your ECG is generally going to look pretty similar too, pretty normal. It's not going to look like any change on the ECG. Clinically used for supraventricular tachycardias, which can occur in like Wolff-Parkinson-White. Afibrillation only as a last resort for refractory ventricular tachycardia. Proarrhythmic, especially post-MI, so you don't give it after an MI, right? Because it's a strong sodium channel blocker. We give the weak sodium channel blocker for weak hearts, not a strong one, right? So it's contraindicated in structural and ischemic heart disease. And that's it. That's your 1A, B, and C. Really easy to remember. They're all sodium channel blockers. They all just have a little tug of war thing going on in the ventricular depolarization. But 1A are the only ones that are really like not that good because of their side effects. 1B seems the best to use because it's got a very weak effect. You could use it on MI patients. And 1C is also fine, not that bad, but you can't use it on someone for long term because it's got a very strong blockade. All right. So you're not going to go ahead and do that. And then down here, I have two questions. One is from Amboss, the other is from UWorld. So let's take a look at that. A 72-year-old man with congestive heart failure is brought to the emergency department because of chest pain, shortness of breath, dizziness, and palpitations for 30 minutes. An ECG shows a wide complex tachycardia with a P wave rate of 105 per minute, an R wave rate of 130 per minute, and no apparent relation between the two. IV pharmacotherapy is initiated with a drug that prolongs the QRS and QT intervals. Okay, the patient was most likely treated with which of the following drugs? And then they gave you a bunch of acid traces. All right, and you had to pick quinidine. So imagine basically that I gave you acid traces from all of these medications on this page, right? And I chose everything from class 1B, everything from class 1C, and chose one medication from 1A. Right, but they tell you that it prolongs the QT interval, and from all of these medications, only that one did. Only the class 1A medications did it. So you had to pick either disopyramide, quinidine, or the procainamide, right? And none of those are trying to find somebody to help me make like a phone app. So she's been reaching out. She's definitely reaching out a little too much, which makes me think if she's like really desperate for money or something, or a scam. Oh God, is this guy really back still? I haven't heard him doing any of that backyard work for a very long time. He's such a headache, I swear to God. Okay, she said no problem. Alright, cool. So these, you always want to remember that because they're always going to give you some differentiating factor between all your other medications. You have to use that differentiating factor to pick the correct answer choice, right? In this question that we just did right now, they only tell you that, one, he's 72, right? He's got all these symptoms: shortness of breath, dizziness, palpitations. ECG shows wide complex tachycardia. So the main issue is just his heart rate is really high. We could also, it's so annoying. I'm just going to end up blocking her because I don't really want help from someone that's that desperate to help me. P wave rate of 105. So where was I? I keep losing track of this shit now. Let me just turn on Do Not Disturb. Okay, I got to remember doing that. This person's heart rate is just really high. So essentially, we could also just give this person a beta blocker. Like, that would be perfectly fine. But they didn't want to test you on that. They're trying to test you on antiarrhythmics. And it does look like he's going to end up having some kind of arrhythmic issue for his age and the palpitations he's having. Right, so R-wave rhythm, no apparent relation between the two. IV pharmacotherapy is initiated, and it just prolongs QRS and QT intervals. So it's not going to be a beta blocker, and some of those acid traces might have been a beta blocker. The real thing, once you get this, is you got to remember all medications that possibly prolong QT intervals, and so far we've only looked at quinidine, which is your class 1A, procainamide, quinidine, and your disopyramide. All right, so that's what they're explaining here. Next one from UWorld, again an elderly patient. So we have an 82-year-old man brought to the emergency department after a syncopal episode. He has no chest pain or dyspnea, but has severe constipation of recent onset. He was hospitalized 2 weeks ago for AFib with RVR, atrial fibrillation with rapid ventricular response, and was discharged home with oral medications after appropriate management. So if you don't know what atrial fibrillation with rapid ventricular response means, that's definitely something you want to go look up, because even UWorld is mentioning that, and Amboss has mentioned it many times, and I've actually heard that a lot when I did my cardiology elective. So I looked it up, I learned it, and I definitely Would recommend you guys check that out too. His past medical history is also significant for hypertension and severe COPD requiring oxygen therapy. Now, if you ever get a cardiac question and they mention COPD, you got to remember you can't give beta blockers, right? Just always keep that in mind. Keep that in mind, because beta blockers, especially if they block beta 2, it's going to be a problematic thing for a patient with respiratory issues. His blood pressure is 105/60, pulse is 50, which is low. So another reason we can't give him beta blockers, right? Beta blockers decrease your heart rate. His heart rate is already under 60, right? It's not 1 beat per second, under 60. So we can't give him beta blockers for sure. Exam reveals bilateral decreased breath sounds and normal heart sounds. ECG shows second degree AV block. Okay. What drug was he most likely given for his current condition? And then they tell you diltiazem, propranolol, and a bunch of stuff. Alright, so basically this is a question on side effects, right? He's got the constipation, he's got this AV nodal block that's happening. And we saw, when we just saw calcium channel blockers earlier, and we're going to see it again later on, that the calcium channel blockers, diltiazem and verapamil, do have this side effect. Alright, so 45% got it right, 27% chose propranolol, which really didn't make sense, because beta blockers don't have this kind of side effect, and we're going to see that. So his presentation with constipation, AV block, and syncope after starting a new medication for AFib is likely due to a calcium channel blocker like diltiazem or verapamil. Both drugs block the L-type calcium channel and slow the sinus rate, as well as exert a negative inotrope effect. Constipation is a major side effect of calcium channel blockade. Beta blockers are commonly used for rate control in AFib and can worsen AV block, but you wouldn't be giving him something like that and knowing he has COPD. Like, he would have never been started on a beta blocker because he has COPD, right? And constipation is not a side effect of beta blocker therapy. So that's what this question was teaching you. Like, there really wasn't a reason to pick this medication as a choice, because why would you give a beta blocker to someone with COPD, right? So that's already something, like, you never assume that a doctor made a mistake in a question unless they tell you that the doctor made a mistake in the question, right? Next one is your beta blockers, right? So antiarrhythmic are your class 2. Class 2 is the beta blockers. So you see here metoprolol, propranolol, esmolol, atenolol, timolol, and carvedilol. Right? So these are the only ones they listed here. But there's so many more, right? And also note that this is not your ventricular. Now we're looking at our AV nodal depolarization, right? AV nodal depolarization. So aldotiberol, all are non-selective beta blockers that block beta 1 and beta 2 except the following. Metoprolol and atenolol are pure beta 1 blockers. And remember when we went back to pharmacology and we checked what was happening with them? And you got to make sure you keep doing that, right? Keep going back and check out this page. So beta 1 we saw has something to do with lipolysis too. Right? Beta 1 increases heart rate, increases contractility, increases renin release, and increases lipolysis. If you stop all of that, then you decrease your heart rate, you decrease contractility, you're going to lower blood pressure by decreasing renin release, and you're going to stop doing lipolysis. And stopping lipolysis is the problem, because that can lead to dyslipidemia. Right? So metoprolol and atenolol, you're often going to get questions where they talk about dyslipidemia. It comes from that. Carvedilol and labetalol, which we've been talking about, they have weird endings, ILOL and ALOL, are beta 1, beta 2, and alpha 1 blockers, so they can actually induce orthostatic hypotension, but they're great medications. And so if you have a patient with a history of COPD or any kind of asthma or any respiratory symptoms, give a cardioselective beta blocker, right? And so you avoid the bronchospasm of beta 2 blockade. Right? And that's really all you got to know for that stuff. If we do go back to page 251 that I've written here, let's see. Yeah, if we come back to here in pharmacology, then you get to see all your beta blockers in their real story. Right? And remember the A to M thing, everything that starts with A to M. Right? Or you could remember the N to Z, non-selective. Everyone from N to Z, beta blockers whose names start from N to Z, are non-selective. And most of them who are from A to M, they're selective beta 1 blockers. All right, so acebutolol, metoprolol, stuff like that. So that's where they're showing here. See, atenolol, beta-solol, blah, blah. These guys are all beta 1 selective. Non-selective ones do both beta 1 and beta 2. So nadolol, prindolol, blah, blah. And then the ones that have ILOL and ALOL endings, these guys are non-selective, alpha and beta. So there's some alpha-1 effects. The only unique one is nebivolol. Nebivolol is very unique and special. It combines cardiac selective beta-1 blockade with stimulation of beta-3. And beta-3 actually causes nitric oxide synthase activity, so you lower your blood pressure by making more NO. So nebivolol is a very cool medication. It's only being spoken about a lot more recently now. Beta-3 receptors are also a more recent thing that's coming up. So these are definitely things that can be on your step one because they're like up-to-date kind of stuff, right? Very recent information right there. And I wrote nebivolol here, but they don't have it in like the list here. And I definitely think it's a great medication, but I'm guessing it's not classified as a class 2 antiarrhythmic. So that's why it's not here. These are your class 2 antiarrhythmics. So what else can happen? Well, first thing, mechanism, they decrease SA and AV nodal activity by decreasing cyclic AMP. And when we studied earlier, looking at phase 4 funny current, the funny current was directly related to cyclic AMP activity. Let me go back and show you that stuff again too, because it's always really good to come back to that. Pathology, yeah, okay. So when we looked at our funny current, we saw right here, right? So this image here is your funny current, the yellow thing, and you can see how cyclic AMP has to come here and turn it on, and it's called the hyperpolarization cyclic nucleotide gated channel. That's your funny channel. So cyclic AMP was the thing that actually turned it on. When we read it that the slope in the SA node determines your heart rate, and acetylcholine or adenosine, which are both pretty much parasympathetic guys, will decrease the heart rate. Whereas things like epinephrine and norepinephrine, right, or sympathetic stimulation, will actually increase the heart rate. So those guys increase cyclic AMP. So it's all directly related to how much cyclic AMP you have. And beta blockers, because that's what beta blockers do, beta blockers decrease cyclic AMP. So you see how phase 4 has been lengthened like crazy. Right? So you can see how it was supposed to go up earlier here, but it got really slow how it's coming up sort of. So you have a very, very prolonged slope of phase 4. So AV node particularly sensitive, and you end up getting an increased PR interval. You can't see the PR interval on this. So keep that in mind, right? You can't see the PR interval on this. There's no PR here. PR interval is about the ECG stuff, right? So you have to remember that when this is happening, this part here, right, this is your atrial depolarization. When this is happening, this is pretty much when you have ventricular depolarization, right, in a sense. But at this point, there's no depolarization that's actually happening in the atria yet. It's just approaching depolarization, slowly approaching depolarization. So at this point, you're not really going to note much. But the PR interval, remember, PR interval was everything that happens before ventricular depolarization. Since we're talking about atrial depolarization, that's your P up to the Q area. All of that stuff is atrial depolarization. So you're going to increase PR interval. Right? So let me show you what I'm talking about. So this part here, this segment here, remember the P wave is atrial contraction. So this part here, this segment is all your PR interval. And anytime you affect your AV node, SA node, you're going to prolong the PR interval. And that's what that means. If you see that in a question, that's what they're talking about. So you can use this for supraventricular tachycardias, ventricular rate control, for AFib or A-flutter, right? Anything where you need to decrease the heart rate, you can use beta blockers, and that's it. But then you have to be careful on who you use it on. Adverse effects. First things first, impotence. So you would rather use beta blockers on female than a male because the male will not be able to have sex. Exacerbation of COPD and asthma. So you never really give beta blockers to someone who has these respiratory issues. Definitely don't give a beta blocker that has beta 2 blockade. Cardiovascular effects are bradycardia, AV block, and heart failure. All right, so basically, this guy. Oh yeah, I unplugged it. Okay, well, it's kind of bad to say, but I do wish he would just die, to be honest. It's like a waste of space. Cardiovascular effects, bradycardia, AV block, and heart failure. CNS effects are sedation and sleep alteration. So all in all, you're seeing a lot of things that are pretty much all sounding like parasympathetic things, right? Because remember, beta 1, beta 2, all of these are sympathetic guys. And then if you're starting to do beta blockade, you're turning on parasympathetic activity of just rest and digest. And then the thing we mentioned way in the beginning with hypertension and diabetes, you don't give beta blockers to diabetics either because it can mask the signs of hypoglycemia. Right? In hypoglycemia, you're supposed to have that feeling of tiredness, hypotension, shakiness, etc. You lose that. Right? And metoprolol we mentioned at the top up here, because of how beta-1 receptors are related to lipolysis, metoprolol can cause dyslipidemia by blocking that lipolysis. Propranolol can exacerbate vasospasm and vasospastic angina. That I've never really seen a big deal about, but I've never seen a question about, but it's definitely significant. I just haven't really seen it. So this is talking about like Prinzmetal angina. So propranolol somehow has a direct effect with Prinzmetal angina, if you can remember that. We've already been talking about carvedilol and labetalol, but other than them, beta blockers cause unopposed alpha-1 agonism if given alone for a pheochromocytoma or for cocaine toxicity. And that's a whole different topic we're going to see later on, but basically in pheochromocytomas, right, you have a lot of norepinephrine and epinephrine, right? And all those guys are going and upregulating all the receptors they can. So if you do the beta blockade first in a patient with pheochromocytoma, you're going to have increased alpha-1 vasoconstriction and no beta-2 vasodilation, and they can just die. That's why in pheochromocytomas, you always do the alpha-1 blockade first so that you can stop the vasoconstriction, and then do beta-2 blockade where you can stop the vasodilation, so you normalize the vessel. So treat beta blocker overdose with saline, atropine, and glucagon, which you can always remember if you remember that it masks the signs of hypoglycemia. Because in hypoglycemia, you give glucagon, right? That's how you kind of help people who are hypoglycemic in essence. And that's really all there is for that. Beta blockers are really easy to work with. Just make sure you watch out for side effects. You're going to get questions on patients that are sounding like cardiovascular issues. They're trying to get better, and then you gave them something, and they came back complaining about impotence. Beta blocker. All right, and that's really all there is for that. Class 3 we said was related to potassium, right? And these are pretty high yield too. So we have our potassium channel blockers. We're back to our ventricular depolarization. And remember, potassium was related to repolarization, so it has no effect on the sodium channel at all. All you're seeing is you really prolonged repolarization significantly. So significantly that you not just increased your effective refractory period, but you've also increased your action potential duration. Both things are increased, right? So you can see that. Increase ERP, increase APD. And anytime you increase your APD, we already understand now that you also increase your QT interval, which then predisposes you to torsades. But torsades has a very unique thing to do with class 3 channel blockers that UWorld actually asked a very good question on, and then I never forgot that topic anymore. So if we look at our medications, they're the AIDS medications in a sense: amiodarone, ibutylide, dofetilide, and sotalol, where sotalol is also sort of a beta blocker, all right? As you could tell from the name. But this one also ends in a weird ending, ALOL, right? So what do? They block potassium channels and inhibit the outward potassium current, phase 3, prolonging repolarization. Atrial fibrillation, atrial flutter, and VTAC. Obvious stuff that you can use it on. Adverse effects: sotalol causes torsades and beta blockade because it is a beta blocker. Ibutylide causes torsades. But look at amiodarone. Amiodarone is a terrible medication in the sense that it causes so many bad effects, but only from prolonged use, right? Not the first time you use it, not the one day you use it. And it does not cause torsades, right? So I have that in bold here. However, amiodarone does not cause torsades. And they actually had a question in UWorld that tested just that one thing, all right? So very important to catch that. Somehow, for some reason, although amiodarone also increases your QT interval, it apparently doesn't cause torsades, which is great. That's perfectly fine. But long-term use of amiodarone has many bad effects. Pulmonary fibrosis, so you can't breathe. Hepatotoxicity, so your liver's not going to function well, and you're not going to be able to excrete medications. Hypothyroidism or hyperthyroidism, because amiodarone is actually 40% iodine by weight. Alright, so all of that in itself, these parts already were bad enough, so you have to remember to check for pulmonary function tests, liver function tests, and thyroid function tests regularly on anyone that has to take amiodarone for a long time. It can also cause corneal deposits, right? And it can also get stuck in your skin, causing blue-gray skin deposits, resulting in photodermatitis. So this picture on the right is before, and then on the left is after prolonged amiodarone use. So you can see how his skin looks really purplish now. It's bluish skin with blood behind it, so very purplish now. Neurologic effects, constipation, cardiovascular effects, blah, blah, not the biggest things. Amiodarone is lipophilic and has class 1, 2, 3, and 4 effects, which is why amiodarone is forever a very unique medication. So amiodarone in itself actually doesn't just do what's happening here, but also has effects of class 1, which will occur sodium, class 2, which is sort of a beta blocker thing, class 3, which is the potassium stuff, and class 4, which is nodal calcium channel blocker stuff. So you are definitely going to get a question on amiodarone, and you have to know all the things it can possibly do. Right? So I have a bunch of notes here talking about some of it in a little more depth, but generally speaking, just remember it doesn't cause torsades. It has this, I guess, triangle of bad effects, and it's got the effects of all different antiarrhythmics. It's a very interesting medication, and it is used. It's not a medication that's avoided. It's actually used pretty often. Then there's this question from Manboss before we go to calcium channel blockers. So, 55-year-old man is brought to the emergency department 3 hours after ingesting approximately 30 tablets of an unknown drug in an apparent suicide attempt. His temperature is 97.7 Fahrenheit, pulse is 40 per minute, respiratory rate is 19 per minute. Blood pressure is 85/50. Examination shows cold, clammy extremities. Scattered expiratory wheezing is heard throughout both lung fields. His fingerstick blood glucose concentration is 62. ECG shows prolonged PR interval. Oh, I hate when that happens. Where was I? ECG shows prolonged PR interval. So when you see prolonged PR interval in your mind, you should be thinking it's most likely affecting the AV node and is increasing something in atrial stuff, right? So you're slowing down your atrial heart rate. So prolonged PR interval and a narrow QRS complex. Okay. IV fluid resuscitation and atropine do not improve his symptoms. Okay. So remember what atropine is supposed to do, and they gave him atropine and it didn't help. Administration of which of the following is the most appropriate next step in management of this patient? Well, first things first, they didn't tell you this patient has diabetes or anything. And no matter what, they gave you this information about his glucose being pretty low, 62. So you see your answer choice of glucagon, you pick it. Why? Because when we saw PR interval, we thought it must be something that affects your affects your your AV node, right? Affects your AV node, affects your atrial depolarization. Something nodal is happening, and beta blockers are nodal, right? Beta blockers, we just looked at it, affects your node, right? Affects the AV node and SA node and all that stuff. So this guy must have overdosed on a beta blocker, right? And all of his symptoms give you that. Like, look at his pulse, his heart rate, very low. Right, so bradycardia, hypotension, wheezing, hypoglycemia, and a prolonged PR interval suggest severe beta blocker intoxication. Patients with beta blocker overdose, IV glucagon should be administered when blood pressure and heart rate do not respond to IV fluids and atropine alone. Glucagon increases cyclic AMP by activating adenylate cyclase, which improves cardiac contractility and heart rate while bypassing the beta blockers, beta receptors. It also improves the hypoglycemia, obviously, by effect of glucagon. So this is why it's very important that after we finish cardiovascular pharmacology, right, what I want all of you to do is go back to biochemistry metabolism, right, and just revise only one thing. You're going to revise just the sugar stuff. So you're going to go back, not even this, you're going to look at this. You're going to look at glycolysis and regulation. Understand how F26 bisphosphate is related to all of this. Memorize that if it's an FBPase, right, the FBPase is this guy, bisphosphatase. As a bisphosphatase, it's actually removing the phosphate off of a glucose, so you're trying to make free glucose. If you're trying to make free glucose, that's gluconeogenesis, that means you must be fasting. Whereas PFK, we always remember as KFC, and that's supposed to mean you ate, right? So as a kinase, you're adding phosphates to your sugar and you're keeping it inside your muscle, right? You got to remember that. Understand how pyruvate dehydrogenase works. Look at this page, right? Understand the TCA cycle, memorize the citrated Krebs starting substrate for making acyl acetate, get that down, right? Look at ETC, and then memorize the reverse pathway, understand all the different tiny substrates that you need to know for every single step, and stop. That's it, right? Because then after that, you're done. This is no longer glucose stuff, right? This is all just different. So up to here, review all of that after we finish cardiovascular pharmacology. That's part of your study schedule kind of thing that you're supposed to do, which I'm still trying to finish up the video for. But basically, after cardiovascular physiology, you want to go back and master the glycolysis and gluconeogenesis and really understand the substrates and the enzymes that are responsible for the intricate balance of maintaining regular glucose control. All right, because that can be tied into any topic. And we're already seeing it being tied in here with all of our antiarrhythmic medications. So now next one here, we have our calcium channel blockers, right? Class 4. We just finished talking about your class 3, which is potassium. So class 4, this is back to your AV node stuff again. So we're seeing the same AV nodal graph here. Verapamil and diltiazem, right? So verapamil is very good with the heart. Diltiazem is midway. In all of your dipines, your dihydropyridine calcium channel blockers, those are all for the blood vessel. So I wrote that here. Verapamil is highly selective for the myocardium, while diltiazem has selectivity for myocardium and vascular smooth muscle, but a little more for the heart. Both medications have no effect on skeletal muscle because skeletal muscle is not dependent on extracellular calcium influx. Verapamil and diltiazem block the extracellular calcium influx, inhibiting the calcium-induced calcium release. And since that won't have any effect on muscle, it doesn't do anything to muscle. Mechanism is decreasing conduction velocity, thereby increasing your effective refractory period and increasing PR interval. And we know anytime we see increased PR interval, you're definitely affecting your AV node and you're slowing down that atrial contraction. So how are we doing that here? But this time, it doesn't really do so much to your phase 4 as it does to phase 0 and 3. So you have a slow rise of the action potential in phase 0, which was calcium coming in. Remember, all of your depolarization in the AV node is actually calcium in this part. A lot of calcium influx, making your charge go from -60 to all the way to +30, right? And then prolonged repolarization as well, which was all potassium coming back out of the cell, right? Prevention of nodal arrhythmias, rate control in AFib, constipation, as we already saw in the practice question, is a major effect. Sinus node depression is another major effect with AV nodal calcium channel blockers, right? And that's really all there is to it. It's really pretty straightforward. This is all calcium over here, calcium influx, you're blocking it. And that's it. Then we have the last few medications, adenosine, magnesium, which we've already talked about as a cofactor for sodium potassium ATPase, and ivabradine, which actually gets tested by UWorld too, and they have a picture for it. So let's take a look at adenosine. Adenosine has two effects, and that's actually summarized by this picture right here on the right. So you can see in vascular smooth muscle, adenosine works on the alpha-2, or it's not alpha-2, it's actually an A2 receptor, the A2 for adenosine 2 receptor. So adenosine actually works on the A2 receptor of vascular smooth muscle to ramp up GS, which makes more cyclic AMP and causes relaxation. So you cause vasodilation and lower blood pressure. In the heart, on SA and AV nodes, there are A1 adenosine receptors, adenosine 1 receptors. It ramps up GI, which is inhibitory, and lowers cyclic AMP, thereby lowering chronotropy and dromotropy. Right, so you decrease heart rate and stuff, and you can see that now if you read it. Adenosine increases potassium out of cells, right? So that's kind of like repolarization, but it actually causes hyperpolarization of the cell, leading to a decrease of intracellular calcium and decreasing AV node conduction. So we can see that, right? Basically with the GI stuff, decreasing cyclic AMP, decreasing chronotropy. So you decrease AV node conduction, lower the heart rate. Drug of choice in diagnosing or terminating certain forms of supraventricular tachycardia. It's very short acting, about 15 seconds. Effects are blunted by theophylline and caffeine, which are both adenosine receptor antagonists. Adverse effects include flushing, hypotension, chest pain, and this is cool, a sense of impending doom and bronchospasm. All right. So it's a very interesting medication, but it's not really a full-blown medication per se. And always remember adenosine, just like, adenosine triphosphate and adenosine monophosphate, that's the adenosine we're seeing here. So if you give adenosine in smooth muscle, it causes cyclic AMP to cause relaxation. In your SA and AV node, it causes a decrease in cyclic AMP, leading to a decrease in heart rate. And that's it. Magnesium is given in torsades and digoxin toxicity because both of them are places where you need to make sure your sodium potassium ATPase is working correctly. And that's really all there is for that. Ivermectin is our last medication that I would always forget, right? We already saw inamrinone, right, and milrinone. So we memorized that with run on. And the other medication was sacubitril, which was lazy to run. Which one was that? Lazy to run. See, if I was to see it on a test, I would know what I'm talking about, though. Ranolazine, right? So I always remember that as lazy to run, and you can remember all the symptoms. So we talked about ranolazine and milrinone in our last video. The last medication that's out of nowhere is ivermectin. So you can also memorize all of the things ivermectin does. Ivermectin prolongs slow depolarization, which is the phase 4 funny channel, by inhibiting funny sodium channels. That's all it does. It inhibits, and you can see this is the image for it coming from UWorld. So phase 403. So you can see in phase 4, you're supposed to have sodium coming in and a little bit of potassium also coming into the cell. And then now, because you have ivermectin blocking it, sodium can't come in, so it takes a little longer. Right? So you have a longer heart rate, slower heart rate. Okay. Chronic stable angina in patients who cannot take beta blockers, give them ivermectin. Or if you have a patient with systolic heart failure, right? Heart failure with a reduced ejection fraction, slow down their heart rate. You always want to slow down heart rate without really affecting contractility too much. Or sometimes you want to slow down contractility and not really increase heart rate. It's really hard to do some of those things. That's where ranolazine, ivermectin, milrinone, these medications come in very handy. And we have another visual issue here, adverse effects. It's very bright vision. Everything's just too bright. But it's not that it's causing pupillary dilation or anything. Everything just looks very bright. Right? And that's really all there is for that. Nothing else. So before we wrap up, I just want to look at this question here, and then I'm going to show you the summary graph. So here, I mentioned two more things. So dipyridamole and regadenoson, which were mentioned earlier in physiology, cardiovascular physiology, they mentioned it. They were the medications used for your coronary stress test. So dipyridamole and regadenoson are actually also A2 adenosine receptor agonists, and they cause coronary vasodilation for stress tests. They can also cause myocardial ischemia in the case of coronary steal syndrome, and that's how you do your stress test, right? Because you give a very small amount, the patient gets chest pain, and you know their coronary artery is not doing well, right? There's atherosclerosis. So dipyridamole, regadenoson, and adenosine all go hand in hand. Then there's Ambos question. So, 75-year-old man brought to the emergency department because of dizziness and palpitations for the past hour. His pulse is what? 185 a minute. Okay, we'll say that's not a typo. 185 a minute, and blood pressure is 100 over 52. ECG shows a narrow complex regular tachycardia without P waves. Yeah, I'm pretty sure it's supposed to be 85, not 185. 85 per minute, which is still pretty high. A drug is administered that activates cardiac potassium channels and causes transient AV block. Which of the following adverse effects is most likely to occur? Okay, so they're giving a medication that transiently causes AV block. And they don't even ask you what the medication is. They want to know what could be a side effect of it. So you're thinking of a very short-acting medication at this point, and the only short-acting medications that we've really seen here so far in all of cardiovascular physiology were your esmolol, which is a short-acting beta blocker, and that does slow down heart rate with your AV node stuff. And then there's these guys, adenosine, dipyridamole, regadenoson, all your adenosine guys. So when you look at the answer choices, chest pain was the only answer choice that really stood out. The patient has been given antiarrhythmic adenosine. Chest pain is a common adverse effect in patients treated with adenosine because it causes transient AV block by increasing potassium efflux from cells, which is exactly what they tell you here, right? Increase potassium efflux out of cells for repolarization, but it causes hyper repolarization in a sense. decreased calcium influx and decreased levels of cyclic AMP. The brief AV block can cause chest pain and a feeling of impending doom as if you're about to die. Other side effects of adenosine include hypertension, flushing, and bronchospasm. Prolonged asystole is a rare but potential complication. And that's it. This is just a very basic question on adenosine. Any other question on adenosine would really be about someone who's been taking adenosine but also takes theophylline or drinks a lot of coffee, like 4 to 5 times a day, and it's not really working because those guys are antagonists of each other, and that's really it. Okay, so Amboss just had this like little summary image that you can definitely like just find online, or just take a screenshot here if you want, where they pretty much put all of them together and put a little summary there for you guys. So it's pretty nice. I liked it. This is also from Amboss, showing you all your different blockades and its effect on your QRS. All right. So the QRS isn't changing, but the rhythm, or your, not blockades, what I'm saying, your stenosis and mitral insufficiency and all that stuff, that's what they're showing you here. So it's the phonograms of your different valvular dysfunctions, right? And it's put in time with your QRS stuff. So you could hear if it's systolic or if it has a diastolic portion to it, right? And so on and so on. So here, these are all actually systolic, right? Because they're all happening in systole. The diastolic ones, remember, D-arms, aortic regurgitation, mitral stenosis. Those are not here. Okay, so that's it. We're done with cardiovascular. Really hope that a lot of this was very helpful. I've done my best to really summarize everything the best and make it like very memorizable. So that's good. Before starting endocrine now, go back and look at biochemistry metabolism and memorize glycolysis and gluconeogenesis with all the correct enzymes and substrates and how it works, as well as the little portion in between with your PDH, pyruvate, and lactate, and how that gets shunted places, and your TCA cycle. Get all of that down perfectly. That's a small portion of metabolism, but a very important one, and you don't want to get any of those questions wrong. All right, and then in the next video, I'll jump into endocrine. So yeah, that's it.